Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being your host today for this episode of GLI Live, where we bring to you patients, physicians, policymakers, all experts in healthcare, really liver health, as we guide uh, with who are immunosuppressed, who have experienced liver transplant, liver cancer. And this month, we are shining a spotlight on rare liver diseases as part of a series, part of the first ever Rare Liver Diseases Month. And so I am very happy to have with me Dr. Cynthia Levy, who is a hepatologist and is Associate Director for the Schiff Center for Liver Diseases at the University of Miami. Hello, Dr. Levy.
Hello, good morning. Thanks for having me.
And I also have my fellow patient advocate, Leslie Stratta, who has self lived with the disease or the condition that we'll be talking about today, primary biliary cholangitis. And so, Leslie, welcome.
Thank you, Donna. Good morning. Thank you, Dr. Levy. Good to see you.
Fantastic. So, primary biliary cholangitis, that's a mouthful, PBC. We'll be talking another episode about PSC. They're often confused if they're recognized at all. So, Dr. Levy, tell us about PBC.
Yes. So PBC or primary biliary cholangitis is an immune-mediated liver disease. So what does that mean? It means that your immune system attacks your own liver, and specifically in PBC, that attack occurs in the very small bile ducts inside the liver. So they over time they get very inflamed, they get destructed and disappear, and that leads to a difficulty in draining bile from the liver. Leads to inflammation in the liver. And again, over time, this process leads to scarring of the liver, which can progress to cirrhosis. Not everybody with PBC has cirrhosis. Actually, most patients, when they're diagnosed, it's early, they don't have cirrhosis. And that's why the name was changed. This disease used to be called primary biliary cirrhosis. But since 2015, recognizing the stigma of the word cirrhosis and the fact that most patients actually don't have it, that nomenclature was changed to primary biliary cholangitis.
That's a fantastic point. I think that name change was a fantastic example of a collaboration between the physician and patient communities to really better adjust the nomenclature to recognize just the point that you made that it's not always affiliated with cirrhosis. And I think that's one of the themes that has been throughout this rare liver disease series. Most people think that, the general public, think that all liver diseases are driven by alcohol, and that they all cause cirrhosis or characterized as that. And so recognizing the 100 different types of liver diseases, many of them based, affecting children and young adults and and women, your neighbors, your wife, your daughter, is such an important part of this. So Leslie and I know why we're interested in rare liver diseases. What got you interested in this area?
I think it all stems from mentorship. So during my GI fellowship, which I completed at Mayo Clinic in Rochester, my mentor because to this day, he's still my mentor, Keith Lindor, was one of the thought leaders both in PBC and in PSC, right, in this country and around the world. And he got me interested. That's how I started doing my research in this area. So many years ago now. And you're right. The fact that it's a rare disease, the fact that it's not just driven by alcohol, all of that interests me. It's a completely unmet need, a field full of unmet needs and a lot of open questions for us to work on. And the patients are wonderful. So, yes.
Well, let's meet one of those wonderful patients. So, Leslie, tell us about your experience with PBC and some of the advocacy work that you do.
So my experience has been interesting, to say the least, but it's also been humbling, and it's taught me that it's okay to be vulnerable. And through that vulnerability, it's my hope that I may be able to help others with PBC. Mm-hmm. I was diagnosed in 2007, asymptomatic. It was detected through just some random routine blood work, which showed extremely elevated liver enzymes. And at that time, biopsy was recommended, mm-hmm. and it showed early stage 1 liver disease, or PBC. And at that point, I was prescribed urso, which is the first line of treatment. And I was fortunate. I responded positively and didn't have any symptoms at the time. And then 11 years after my diagnosis, again, I had a spike in enzymes, and it became mm-hmm. clear that I wasn't responding to the urso as I once was. And then another biopsy showed a stage 3 progression. And I was prescribed another treatment with Ocaliva. So I'm grateful that has helped me. Definitely seen my enzymes return to normal. I will say, from an experience standpoint, all PBC patients respond differently. Different things work. That's what makes it a little bit more frustrating. And I think the really need for us to advocate for ourselves, because we do try to support each other through our community groups and help each other, but we all just respond so differently. It's just that unknown of how your liver functions and how everything works within your own body and what's happening in autoimmune. It's just that mystery. And I'm very hopeful that with the research that Dr. Levy is doing and the new things that are coming online can give us a better picture, a better idea of, how we can take care of our livers, because we know the liver's resilient. And, in some cases, things that you do on a daily basis can definitely change the course, or at least slow it down. So that's always the hope, is to slow that down. I have developed some symptoms over the last 10 years, mostly fatigue and itching, Paritis, which I know we're going to probably address here soon. And so, I've just basically learned to do what is right for me in terms of managing that and providing support for each other, and knowing that although it's mystery and rare, there is research being done. And so there's hope on the horizon.
So, Leslie, before we get to the research line, I'd like to ask Dr. Levy about the screening and diagnosis. So Leslie mentioned that her doctor actually paid attention to the liver enzymes on her blood work, on her panel. Do you think that enough physicians are paying attention to those liver enzymes and catching all of the potential cases of either PBC or different types of liver diseases?
Those are fantastic questions. And also, Leslie touched on so many important points across the entire spectrum of care for PBC. So let me address some of these points. Okay. I'll get to your question. So the fact that we don't know exactly what triggers PBC, as I said, a mystery, right, makes it harder sometimes to identify this link of the cause and the disease. What we know, that there's a genetic background. So genetic predisposition, first-degree relatives that are a lot more common to develop PBC than an unrelated individual, right? We know, and there are familial clusters. There's high concordance rate among monozygotic twins. So we know there's a very strong genetic background and predisposition. And then there's something from the environment that triggers the disease. And what that is what we haven't pinpointed. There are several things that have been proposed: infectious agents like E. coli and other bacteria, medications, drugs, hair dye, nail polish. Several things have been reviewed in case control studies that could maybe help trigger the disease. But we don't know exactly when that happens. It's like a hit and run. By the time we diagnose, that exposure happened years prior, right? So as was the case for Leslie, most patients are now diagnosed when they are asymptomatic. The labs are picked up during an evaluation for insurance, for instance, or for a job, or due to an unrelated problem, and you get to check your liver enzymes and they're elevated. Many times, physicians brush it off a little bit, as you said, may not pick it up. If it is a mild elevation, they may brush it off and just keep monitoring them. But there are very strict, well-established diagnostic criteria for PBC, which we need to advertise and promote. There are guidance documents that we have published to remind people how to do that. It's a rare disease.
And just to help, if we have primary care doctors or pediatricians listening, what are, we'll put the link to the AASLD guidances in the notes for this. But what are the key things that they should be looking for? Elevated liver enzymes,
so it's specifically the alkaline phosphatase that is elevated, right? So we'd have to have 2 out of 3 criteria: elevated alkaline phosphatase without an explanation for it. I will tell you why I'm highlighting this. A positive antimitochondrial antibody, which is present in over 90% of the patients, and typical histologic findings. So findings on the liver biopsy, as was the case for Leslie. So you need 2 out of 3. What is important here? First of all, elevation in alkaline phosphatase is quite common. There are many causes for this, and PBC is a rare disease, but we'll keep that in mind. So for instance, fatty liver disease, which affects a third of the population, can course with an elevation in alkaline phosphatase. We keep that in the back of our minds. AMA positive, so as I said, 90%. So if the AMA is negative and you have an elevation in alkaline phosphatase, you must have a liver biopsy before you make a diagnosis of PBC. You cannot just presume, elevation of alk phos with AMA negative PBC. No, you need to have a liver biopsy. Or if the patient has other potential explanations for that alk phos, then we also suggest a liver biopsy in those cases. You mentioned about pediatricians. Well, PBC is a disease of the adult, different from PSC, which can present in 4-year-olds, 5-year-olds, right? PBC, the mean age of presentation is in the 50s. Okay. So it's a rare disease, but when you focus on middle-aged females, it's 1 for every 1,000. So we have to know what we're looking for, right?
That's important. I pick up on the point of biopsy because often, patients are scared from, getting diagnosed or treatment because they're scared of a biopsy. And I know we're evolving, various types of non-invasive diagnostics. But Leslie, can you just walk through from a patient perspective what your biopsies were like?
So my first biopsy, of course, I was, a little bit fearful. I mean, I actually recommend when you're originally given a PBC diagnosis to really rely on your physician and your care team and not research it. And research biopsies and look up Dr. Google because, unfortunately, the internet just stores all this information, right? So there's information from, the first known case of PBC, and so it can be a little distorted, and it can make you fearful. So going into the biopsy, I trusted and respected my physician, my hepatologist, my patient care team. I did not have any complications. The process was fairly easy and straightforward. I was given the information, and I am a researcher. I should have been a scientist or a researcher, and maybe I will be in another life, but I keep every single document, every single blood work, liver enzymes, everything. So I have it. So I wanted to see what was on that paper and really understand what they were looking at when they looked at that biopsy, knowing that your liver is big, right? It's a fairly large organ, and what they were going to take from that liver and how they were going to get that diagnosis. And once I understood that it was the damage to the bile ducts, it gave me a little better understanding of, oh, okay, so it's a slow progression of damage, and that's how they get the staging. So the experience, the actual procedure itself, was, to me, it was very easy, no complications, and I was explained what was going to happen before, during, and after.
And I think that's important to give context, so that patients know, what to expect.
Yeah. The truth is, we do the biopsy less and less often now for PBC. We don't have to do a biopsy to diagnose PBC in the majority of the patients. There are some cases where we need it. The risk is low. There is a risk. It's an invasive procedure. Same risk as a colonoscopy in terms of the frequency of complications. So it's 1 in 1,000, So as you said, some trust, some conversation, good explanation beforehand. The doctors, we always need to assess risk and benefit before making a decision to proceed with an invasive procedure. And we want to know that will really change the management for the particular patient before proceeding. That's very important.
Fantastic. And so on our, walk through the patient physician journey and management of PBC, one of the top symptoms and issues along the way is Paritis. So I'd love to hear both sort of the clinical view of how it's managed and the patient experience of living with it, and maybe sort of what you put together and do at home. I haven't experienced it myself. It's more than just a little itching, and as we pull together the GLI Pediatric and Rare Disease Liver Council, it's one of those overarching symptoms of so many rare liver diseases that we feel if we could get, research and really address that issue, we'd be providing a lot of relief to several types of rare liver diseases. But Dr. Levy, can you start to explain, what it is, why it is, and what people do about it, and then Leslie, how you've coped with it?
Yes, so pruritus along with fatigue are the two most common symptoms of cholestatic liver diseases, or diseases where there's impaired bile flow, right? What causes pruritus? We think it's multifactorial. There are several theories that have been put forward. Accumulation of bile acids is one of them, but it doesn't explain itching for all the patients. There is no direct correlation between the levels of bile acids and the intensity of itching, frequency and intensity of itching. There are other neurotransmitters that have been proposed. The lysophosphatidic acid pathway is one that has emerged over the past few years, and we're developing more and more about that. So right now, in terms of, I would say about 70% of patients with PBC at some point report itching. For most patients, it tends to be mild, but for a minority, maybe 10% of the patients, it can be severe and refractory. So it's a wide spectrum. Itching is so important because, first of all, many patients don't associate the itching with liver disease. So they don't even mention to the physician. It's on us, doctors, to ask the patients about their specific symptoms so that we can address, manage, document. Second, our ability as physicians to really understand and quantify the symptom is really poor. There have been studies. This happens in other areas in medicine too, but we specifically looked in PBC. The correlation between what we put in our notes and what the patients fill out in specific questionnaires is horrible. It's very poor. Of course, when the patient has very severe itching, then we tend to pick that up and we improve our ability to diagnose. But the truth is, many physicians don't ask, they don't document, they don't manage itching. So we need to ask. Because what causes itching is a little elusive, like we're still working on it, specific therapies become difficult, right? So our guidelines have suggestions for physicians on how to manage this.
Mm-hmm.
Usually, my approach to itching, it depends on the intensity. I work with the patients, so I always ask how is this? How bothersome is it? Because itching is not just scratching, and Leslie will tell you,
Mm-hmm.
our audience, what her experience is, but it affects sleep. Therefore, you're fatigued next day. It's embarrassing socially. You will feel like that leads to social isolation, depression. Family members don't understand this. Your partner will be asking you, can you please stop scratching in front of this or that person, as if this is something that you could control. So it carries a lot of consequences. It's a burden and impairs quality of life of patients with PBC. Very important to recognize that. So this is something that we should discuss. If it is mild,
Mm-hmm.
I always ask, do you want a medication, or is this something you can handle? Because some patients don't want to be on more medications, right? And ursodiol, which Leslie mentioned, is the first line therapy for PBC. It should be started for everybody. Does not treat itching in particular. It's not a treatment for the itching. It's a treatment for the underlying disease.
Mm-hmm.
So many times you just do conservative measures. Okay, you use a lot of moisturizer, you avoid tight clothes, that can avoid hot showers, trim your nails so that you don't get excoriations on your face, on your body. You do those, you carry those measures. There's aloe, Aveeno bath, things that work for different patients, right? Each one of you is very different. If that doesn't work and it's still impacting patient's life, next thing I try is usually cholestyramine, because that has been through the test of time. It's a safe medication. It does have some side effects, but as long as we have this conversation and I tell you, okay, you may feel bloated after you take cholestyramine. So let's take the first dose at bedtime when you go to bed. So you sleep off on any side effects. Let's increase the dose gradually so that you don't feel all these side effects at the same time. And we need to, it has a very particular pathology, so you cannot take it together with other medications, including the USO. You need to wait 3 or 4 hours between the medication. So for some patients, it's easy to do. If you only need a nightly dose, that should be fine. As we start to increase the dose, or for patients who take a lot of other medications, it can be hard. So when cholestyramine fails for whatever reason, there are other options that we can try. Rifampin is an antibiotic that we can use. It's very effective for itching. It does carry a 5% chance of hepatotoxicity, meaning increase in the liver enzymes. For some patients, this is unacceptable and they don't want to try, but it's very efficacious. So many times this is a good resource, especially patients who have their disease very well controlled. We can try sertraline, which is an antidepressant, but has also been shown to improve itching in uncontrolled studies with a small number of patients. So this is something we can offer. Fibrates, which are an off-label therapy for PBC. So fibrates are medications that are approved for the treatment of hyperlipidemia, right? But they also have been shown, they are PPAR agonists. They activate a nuclear receptor that actually leads to improvement in cholestasis. So they are being evaluated broadly for PBC. Various classes of PPAR agonists are being evaluated for PBC and in PSC as well, by the way. They also have been shown to improve itching. So anecdotally, they have been shown, and in small clinical trials, like the Besurso trial in France and the Fitch trial, they have shown that fibrates improve itching. So that's something that I can use, and it's very efficacious also. And by that, I mean fenofibrate, for instance, in the United States.
That's wonderful to hear that there are so many options, because I think often patients think that there's just nothing to be done. I know from a policy perspective that GLI is working to make sure that there is access to all of these options, and we know in some countries, access to these options is an issue. So Leslie, what has experiencing this been like, and what have you done to cope? Because you look very calm and very.
So I am very fortunate. I have mild to moderate itching, and it's intermittent. When I remember earlier, I said there's kind of no method to the madness, right? It's for me anyway. So and these are not scientifically proven. They work for me. I do think that I do notice that when I'm dehydrated, that can affect how I feel and how the itching comes on. So staying hydrated, definitely staying moisturized. I make sure that usually it's at night, when I'm lying in bed and trying to relax, and one little spot of itching then just kind of starts crawling all over. But I do find that if I can hydrate at night and use some of the topical solutions that Dr. Levy mentioned. So keeping moisturized, again, avoiding really hot showers right before bed. The heat just seems to exacerbate the itching. And then for me, you mentioned calm. I do try to every evening do a meditation, kind of a relaxation, right before bed. I have an app on my phone. They're there's lots of them out there. And then it may seem counterintuitive, but I think stretching and exercise for me, at least at some point during the day, I know I just said heat exacerbates it. So not an extreme exercise, but just some type of movement, I think for me, and maybe that's just a mental releasing
the nervous system,
releasing the serotonin for the day. And then doing the meditation at night is really, really helpful for me. So those are just a few things that have helped me.
I think that's fantastic, and I think that will help so many people who are listening. Leslie, let me stay with you for a minute. You've mmade that bridge from patient to patient advocate, and we've had the opportunity to talk about that. You're excellent communicator, and so tell us about how your advocacy has evolved and the types of issues that you work on with fellow PBC patients.
So I try to stay active in the community. There's a Facebook group out there. There's PBC Foundation, the PBCers organization. There are groups in almost every city for folks who, if you have a Facebook account, which most of us do, look to those groups. There are online meetings, virtual sessions. The American Liver Foundation has a Facebook page as well that you can join. Most of the criteria are that you have PBC or a family member with PBC to be able to join those groups, just so that we're sharing information that is relevant to PBC and to what's going on maybe in our families. Dr. Levy mentioned just the family component of not understanding perhaps what we deal with sometimes maybe with itching or fatigue. And so, I also work with the folks at Intercept and Intercept the Connect, and working with that other line of treatment with Ocaliva, and making sure that, talking even with physicians sometimes when I go even to my primary care physician, or if I'm going to, I also have Hashimoto's thyroiditis, which, 12, 13 years ago, had I known I was diagnosed with that first, which kind of all the dots linked together. But, talking to all physicians, talking to the gynecologist even, hey, do you typically test for liver enzymes? I personally think it should be a part of your physical dashboard. You get your blood pressure checked, you get your cholesterol checked, you get your A1C checked, you get your liver enzymes checked. I'm just not understanding why that isn't there. And so that's what I'm advocating for, is regardless of which physician you see, make sure you, that should be a part of the know your numbers, right? I mean, we say that that's kind of a catchphrase in healthcare, know your numbers. Well, know that one, because that's important.
You're absolutely right. So the Know Your Numbers campaign started from blood pressure.
Right.
Able to know your blood pressure, and liver enzymes are included in a comprehensive metabolic panel. But that's what I sort of just brought up the point, and I did not mean to put you on the spot, Dr. Levy, with your other physician specialists. But I've just heard so many from patients who were ultimately diagnosed with a liver condition that when they look back, they're like, oh, my liver enzymes actually have been elevated for a number of years, and either my doctor and I didn't discuss them, or I was told, well, don't worry about them, or we'll repeat them in a year. And in the meantime, their liver disease progresses, it gets more serious, and then they start to have complications, or referred for transplant or something. And it's only in that sort of look back, that sort of retrospective, that they're like, they've been elevated for a while. We just didn't take action. So, Leslie, to your point, they are there. We just need to make sure that people are focused on them and understand how to use them, and what actions they might trigger in a clinical workflow, I think.
Yeah, I agree. I suspect that I had PBC at least 2 years before I was diagnosed. I actually had elevated liver enzymes 2 years prior to being diagnosed. And, even though I was seeing at that point a primary care and a gastroenterologist, there just was so little known about what to do with that, right? They were asking me again about, well, how often do you drink and how much do you drink? And I mean, the focus back then in 2002 and 2005 was still so much around alcoholic liver disease and hepatitis C, right? So those were all the things that they were testing for. And when they ruled that out, there wasn't really any more action. Well, we'll just keep a check on it, come back in 6 months, come back in a year. And it wasn't until it was actually my thyroid doctor that said, how long has this been going on? Let's look at your medical records. And she's the one that said, oh, wow. Yeah. Go across the street and see this gastroenterologist that specializes in this, because there's something going on. And that's eventually how I was diagnosed. But
I think that you point out, one of the essential values of the Pediatric and Rare Liver Diseases Council, because we do convene multiple specialists, and we've worked so closely with endocrinologists who would treat thyroid disease in our NASH council and other areas, and bringing people to the table to be more cognizant, to have sort of common education on rare liver diseases, to increase diagnosis, and to lift up several of the organizations that you've mentioned as well, so that collectively we have a larger impact and share a voice. And one of the things I know on is research and supporting that. So Dr. Levy, tell us about what's on the horizon from the research pipeline. What should patients be looking for and having hope to see in the future?
Oh my God, there's so much going on. So I'm glad you asked. There's a lot going on. So there's research focusing on new therapy. So just to recap, the treatment for PBC, as mentioned, ursodiol or ursodeoxycholic acid, 13 to 15 milligrams per kilo per day is the standard first-line therapy. One new thing in the treatment of PBC is that we have second-line therapies, like as Leslie mentioned, and we've learned more about the progression of the disease. So now, once you make the diagnosis and you start your treatment, you don't forget about the patient anymore. You have to bring that patient back and repeat labs every 3-6 months, however you decide your plan, depending on the severity, and assess for response to therapy. So we have well-defined criteria to assess whether a patient is responding to therapy or not, because as early as, the recommendation at this time is 1 year after treatment with ursodiol is initiated, we have to determine if that patient is responding or not, so that we can move forward with adding the second-line therapy. Ocaliva is the approved second-line therapy, or obeticholic acid. Half of the patients who take that will meet the endpoint that was used in the clinical trial. Any improvement in the alkaline phosphatase is good. We want to see normalization, but any improvement is good, and patients improve with Ocaliva. But there is still an unmet need there for the patients who don't normalize, right? So there are several clinical trials going on exploring different mechanisms of actions, different fibrates, different PPAR agonists. So moving forward in phase 2 and 3, we have seladelpar, we have elafibranor, we have saroglitazar. Intercept is combining obeticholic acid with fibrates, so there will be another study coming up. Loads of options. That's important to know that, okay, if you don't respond, there is something that we can do for you. It's important to continue monitoring, seek a specialist, seek a research center. And for pruritus, which thankfully in your case, it's mild to moderate, but there is a subset with moderate to severe. It's really hard to manage. And there are clinical trials as well. So at this time, there are 2 clinical trials, 2 different mechanisms of action. So we have drugs that prevent absorption of bile acids, and we have other drugs that just prevent the scratching behavior. So a totally different mechanism of action. But again, the point is we're developing new therapies. There is hope, there's always something that we can offer. So look for a specialist.
I think that is, having stayed sort of one step behind innovation, how I say, how over the course of my 30 some years with since my first diagnosis with GI diseases, and 20 some years for my first diagnosis with a liver disease, that knowledge that there's going to be something on the horizon, something, even if what I'm currently on isn't working, there may be something that will be coming out soon that can help. And in my case, that has always been proven true. Otherwise, I wouldn't be able to be sitting here today and able to do the work of GLI. And so I consider it an honor to be able to help. Also, many of our the graduates of the Advanced Advocacy Academy at GLI are involved in protocol development and lending patient insights into research. We've helped in special programs of research excellence in different areas and I actually was the patient representative on the OCA advisory committee at FDA, and so playing that role and having that, bringing that patient perspective alongside with those who participate in the research, and builds that culture and that data that way. It's exciting to be part of the different roles that patients can work alongside physicians and researchers and industry sponsors to create the hope for tomorrow.
Absolutely. More and more the patients are participating in this process. The companies are seeking your help to develop the new protocols, to see what is acceptable, what's not acceptable, how much risk would somebody take or not. It's extremely important so you can tell us what you value the most, even to develop the better better surveys, better instruments to assess your symptoms. We need your input, really, or we can't move.
We are here. Resources I would be remiss if I didn't mention in the PBC space. One, Leslie, you mentioned the PBC Foundation in the UK, and the wonderful work they've done in the digital space, collecting data and allowing that to be fed in on patient symptoms. And there's one more resource too. I believe I have it. Yes. So the PBC Foundation book on living with PBC is a fantastic resource. I also know that they've done lay versions of the PBC guidelines that will make sure are available in the notes. So I wanted to give them credit for all that they have contributed to this field, and thank Robert Mitchell Thane for his partnership in PBC always, and in health leadership. It's fantastic as we attempt to unite PBC patients around the world. It's so important in a rare disease to make sure that we're getting every patient everywhere. And the PBC Foundation is a very important partner to the Global Liver Institute. So I wanted to give them a shout out for the resources that they've created.
Absolutely.
So any final takeaways? Dr. Levy first, and then Leslie, I'll let you have the last word before we leave here today. Dr. Levy, what do you want people to know most?
Wow. Increased recognition. So as you mentioned, liver enzymes are part of the CMP. So we do that. Physicians they do that every year for adults. So increased recognition, taking the next step as far as workup. Patients, as much as you can advocate, you also help push and guide your physician. That's super important, right? So what I want people to know, there are resources out there. Look at the guidelines, make referrals. There are options for treatment, refer patients for clinical trial participation, and so that we can develop these new therapies. Just knowing that there is hope and there are so many people willing to help. You mentioned PBC Foundation. There are also the PBCers in the United States. They're a smaller group, but also there with resources, doctors panel questions, conferences that help address your concerns. So participation, global participation is what's of utmost importance.
Fantastic. And that is exactly what we're here to facilitate. So thank you for bringing them up again, an important partner. Leslie, last word.
Yeah, I just think as a patient and an advocate, I think that it's important to join those communities, get the knowledge that you need from folks who have experienced it. I think I spent a lot of time early on researching the why. Well, was it environment, genetics, and so I encourage people to, yes, that's important. And that's what Dr. Levy and her team are trying to figure out so that we can hopefully prevent it. Mm-hmm. But our job right now as patients and advocates is to figure out how we can keep the disease from progressing and what we can do individually to help ourselves live in this space and manage the disease and the disease progression, and just support each other. I do think that there's a large support network out there. And I think we should all be hopeful that Dr. Levy and the other folks in that space are coming up with new treatments. I have participated in some clinical trials, so I do encourage folks to step up and do that. And if you have questions about it, to ask our community. There are a lot of folks that are in clinical trials in our community, and we post those regularly to social media for especially the PBCers. I know I just saw something recently where they had posted a list of clinical trials. So that's how we can help. That's how we can continue to support each other, is by participating in those trials to help better understand the disease and to, hopefully, come up with a cure someday. So, there are lots of pieces to the puzzle, and we all have our own individual piece that we can contribute. And, the goal is to get the puzzle fixed one day so that we can see what that looks like, what the future looks like going forward. So.
That's fantastic. So I look forward to the day that there is a cure, and in the meantime, we will do our part, and we'll make sure that we make it very easy at the Global Liver Institute for people to know what role they can play, and serve as a central repository for all of those resources so people can take. So I thank you, Leslie. Thank you, Levy, for being with us today. And until next GLI Live, you can find all of our information on globalliver.org and on Facebook and Twitter. So Stay well and stay connected.